Can you guys see the slide rather than the presenter view?
Yes, we can.
Okay, perfect. I'll take it away then. So good morning, everyone. I'm going to be speaking obviously about diversity, equity, and inclusion in otolaryngology. I really started to delve into this topic a little bit more about a month ago as we began to conduct interviews for our residency program. Like most of the interviewers, I was struck by how incredibly qualified the applicants were. But among these applicants, there were several that stuck out for reasons beyond their academic success. These applicants poignantly wrote about the challenges they had faced, socioeconomic, within their families, or with limited opportunities where they had grown up. And many of these applicants happened to be underrepresented minorities or women. And I began to think about how these subjective life experiences should factor into what is supposed to be an objective, merit-based system. And that question led me to look into this topic more. So I don't have any disclosures, but I'll be the first to admit that I hadn't thought much about this topic prior to that. And that might be because I'm an Indian American male, which is likely the most overrepresented group in America, with Patel and Khan being two of the most common last names amongst British and American physicians. So what is DEI? It's certainly not a new concept, but in the context of a broader discussion regarding race in our country, interest in the topic has increased tremendously over the past 2 years. The topic has become an area of focus in every major industry, and medicine is no exception, with research publications focused on DEI increasing fourfold. And there's obviously three arms to this. Diversity relates to understanding and acceptance of the differences that each individual has, similar to what I mentioned with the residency application process. Equity relates to fair access to opportunity and impartiality within an organization. And inclusion is about hearing or integrating a group's ideas. Essentially, does everyone have a seat at the table? And together, these create the conceptual foundation for DEI. This is a quote that I thought was a nice framework for describing what the goals of a DEI initiative really are. I'll let you read that on your own, but this is from the mission statement of the Ohio State Medical Center. And so diversity is a broad term. It relates to pretty much any differences that a group of people can have. Those can be differences in race, ethnicity, sex, socioeconomic status, disability, where you're from, gender identity, sexual orientation, whether you're the first in your family to be XYZ, or a military veteran. And it's also important to note what diversity is not. It's not a political term. I believe that DEI in this context is an opportunity for quality improvement within medicine today. And I'm going to try to present this in a manner that reflects that with the evidence that's available. So within medicine, most diversity efforts and research has been focused on two groups: underrepresented minorities and women. In 2004, the AMA defined underrepresented minorities as racial and ethnic populations that are underrepresented in the medical profession relative to their numbers in the general population. And that is primarily four groups: African Americans, Latinos, Native Americans, and Native Hawaiians. So a brief primer on the history of diversity in medicine. Dr. James McCune Smith was a former slave who attained his medical degree in Europe and then later returned to the United States, becoming the first Black physician in 1813. Elizabeth Blackwell is the first female to receive a medical degree in the United States in 1849. Rebecca Lee Crumpler was the first African-American female to earn an MD in 1864. Within otolaryngology, Alice Bryan is the first female otolaryngologist. She had a prolific career and was later the second woman nominated to the American College of Surgeons. And William Henry Barnes was the first African-American otolaryngologist and board-certified surgeon when he graduated in 1913 from the University of Pennsylvania. So why does diversity matter to us? Well, the racial demographics of the United States are changing. By 2045, the US is projected to become a minority-majority country, meaning that Caucasian Americans will represent less than 50% of the population. And we're going to see a corresponding increase in diversity with that. African Americans are projected to become 15% of the population, Asian Americans 9.1%, and Hispanic Americans over a quarter of the population. These trends represent both the future of our patient population and our workforce in healthcare. And despite these changes, a growing body of evidence shows that healthcare disparities exist for minority patients in virtually every field in medicine. I think we all remember learning in med school, hearing time and time again that a disease had worse outcomes in minority patients. And these are present in healthcare in every single aspect: cancer care, surgical care, heart disease, pregnancy. And they're responsible for real-world costs as well. A study estimated that between 2003 and 2006 alone, healthcare disparities were responsible for over $200 billion in additional costs. And this is also true for gender disparities. Women have historically been believed to be more emotional, which can affect care for pain and mental health. Male presentations for acute diseases are more commonly taught as the classic presentation, potentially leading to delays for women in the diagnosis of acute conditions like MI, strokes, or acute abdomens. And otolaryngology is similar as well. There's been disparities found in various categories based on race and socioeconomic status. One of these papers is actually from our group and Dr. Johnson at Children's Medical Center. But minority children are less likely to be diagnosed with otitis media and pharyngitis. They're less likely to be implanted with a cochlear implant in a timely fashion. As Dr. Johnson mentioned, Black children are more likely to undergo tracheostomy, and they have decreased survival for various different head and neck cancers. The gap in outcomes here between different genders and races is a complex relationship of those characteristics, as well as social determinants of health and implicit bias. So social determinants of health include socioeconomic status, health insurance, somebody's ability to access medical care, and adherence to treatment. And to sort of see this in action, it's important to note that minority zip codes have fewer medical providers, and thus a large portion of minority patients use a relatively small number of American hospitals. And these minority-serving hospitals tend to be poorly resourced, exist in non-academic settings, and thus are less likely to have subspecialty services. And that might be why in our field, minority patients are more likely to have pituitary surgery and thyroid cancer surgery at low-volume centers. Those are associated with higher complication rates, higher costs, and for thyroid cancer, those patients are less likely to receive RAI when appropriate or be treated in adherence with national guidelines with worse survival. And in contrast, if you look at studies of laryngeal cancer patients at the VA, where some of these social determinants of health are mitigated, they've found that African American patients present at the same stage, receive guideline adherent treatment at the same rate, and have equivalent survival as non-African American patients. And that takes us to the last point of implicit bias. So this has received a lot of publicity. It was first described in 1995, and it can essentially be summarized as the presence of stereotypes. Some of these stereotypes are taught to us, and others are learned by experience. And this is in part natural. The ability to quickly and automatically categorize things is a fundamental quality of the human mind. Our brains are wired to notice patterns and make generalizations to allow us to operate in part on autopilot. However, the issue is once these are formed, they're very hard to change, and we have a tendency to look for stereotype confirming information that can lead to implicit bias. And it may create the opportunity for even well-meaning providers to have differences in the care they deliver. This can pertain to numerous characteristics. It's not just race or gender, but it can be towards obese patients, different cultures, different languages. And large studies have shown that implicit bias is common at about equal degrees in healthcare and the general population, and most individuals are unaware of their implicit biases. To see examples of this, African American faces with the same facial expression are perceived to be angrier, and that may have effects in the sense of charting. Black patients' charts are 2.5 times as likely to include terms like non-compliant or resistant. That may perpetuate bias against these patients when the next provider reviews the chart. Women have been found to be 3 times less likely to receive indicated knee surgery, and that's because women are perceived as less stoic and less likely to complete rigorous activity. There are studies in the business world that demonstrate this too. White applicants get 50% more callbacks than Black applicants with the same resume. Another illustrative example in our field as surgeons is with opioid prescriptions. So myths persist regarding Black patients feeling less pain. This sounds crazy, but in 2016, 40% of early medical students believe that Black patients have thicker skin that's less prone to feeling pain with needle sticks. These trainees are less likely to treat Black patients' pain appropriately, and Black patients have been found in numerous settings when presenting with extremity fractures, for children with appendicitis, or for patients with metastatic cancer to be given less pain medication and at lower doses. And in our field, Black patients are found to be less likely to receive opioids after a tonsillectomy. So with that context, it's obvious that having a diverse workforce isn't going to fix all racial and gender disparities, but it's a critical portion of the process. And there are really 3 main points to the case for increased diversity in medicine. The first is the improvement in healthcare outcomes. Black and Hispanic physicians practice in areas with more minority patients, more uninsured patients, and more Medicaid patients. Racially concordant visits have been found to improve medication adherence, last longer, and have lower wait times. They also have more detailed noting with improved patient adherence. So there's no surprise that these visits lead to improved patient satisfaction and improved perception of communication. And that's important to note that this isn't to limit the value of minority physicians to narrow aspects of care or to burden them with being flag bearers. It obviously doesn't argue that we should only have racially concordant patient visits or to denigrate the efforts of non-minority physicians who care for the disadvantaged, like many of our physicians in this room. Nonetheless, it's clear that the preferences of physicians in choosing their settings and the patients in choosing their physicians combine to create an outsized role for minority physicians in the care of minority patients. Female physicians in studies of over 1.5 million hospitalizations have been found to have lower 30-day mortality and readmissions in the hospitalist setting. There's also a closer adherence to evidence-based medicine and guidelines, more effective communication, and longer visits. In surgery, they've been associated with lower postoperative complications and death, with most of this effect being driven by improvements in gender concordant pairings, so female surgeons taking care of female patients. Within research, underrepresented minority patients have historically been very difficult and difficult to recruit and underrepresented in research studies, but that's been found to be improved if the study team is diverse. Minority physicians investigate and publish on healthcare disparities more frequently, helping bring them to light. And publications have been found to be higher cited and published in higher impact factor journals if they have both male and female authors. And this may indicate improvement in the research quality with a diverse team. And that's not surprising and leads us to our second point, because diversity may have cognitive and organizational benefits. The business world has really led the way with research regarding this, but to put it with this quote, diversity within teams jolts us into cognitive action in ways that homogeneity simply does not. And the addition of diversity of teams has been found to make the group prepare more comprehensively, anticipate alternative viewpoints, and expect that reaching consensus will take effort. And these benefits may help us address the complex problems facing medicine today. The Harvard Business Review published an editorial about why diverse teams are smarter. They found that in studies of mock jury panels, one diverse and one homogeneous, the diverse panels raised more facts related to the case, made fewer factual errors discussing evidence, and corrected those errors more quickly. Studies of financially literate individuals who were simulating stock prices found that diverse teams are 58% more likely to price stocks correctly and are more likely to examine facts and remain objective. McKinsey does an annual study in 15 different countries on hundreds of companies. They looked and found that the top quartile of companies in regards to gender diversity or racial diversity in management were between 28 and 35% more likely to outperform those in the bottom quartile of gender and racial diversity. Another study found that Fortune 500 companies with diverse boards made more accurate risk assessments, improved innovation, and avoided bubbles. And the notes here about diverse leadership are important. It signifies that these companies are not only hiring a diverse pool, but are giving opportunities to non-traditional leaders to rise to positions of leadership, or the concept of equity and inclusiveness. And similar studies have found cognitive benefits for diversity in medicine as well. And finally, we have a moral imperative. Essentially, we should be striving to create a system that ensures that a medical student's gender or race has no impact on their potential within medicine broadly or our field of otolaryngology. So, where do we stand with that being said? The number of female applicants to medical school has slowly risen over time and now outnumbers the number of male applicants. That hasn't quite reached our workforce yet, as about 2/3 of current physicians in the workforce are males. When we look at data by race, applicants to medical school comprise just under half of all applicants. Asian Americans are 21%, African Americans are 8.4%, and Hispanic Americans are 6.2%. The rates of these minority applicants are clearly below the rate of these groups in the general population. And when we look at active physicians by race, African Americans comprise only 5% of active physicians, and Hispanic Americans comprise 5.8%. And this sort of scarcity of minority physicians has big implications when we talk about the role for mentorship later. When we look at our field specifically, the percentage of female otolaryngologists is rising over time. It's risen from 11.2% in 2007 to 17.1% in 2017. but it remains low compared to the larger population. Overall, we're doing okay compared to other surgical subspecialties. We're in range with plastic surgery and general surgery and with neurosurgery. When we look at trainees, so otolaryngology residents, we've improved there as well. In the decade from 2007 to 2017, we increased from 27.5% to 36.2%. When we look at women in leadership, there's still work to be done to make this more equitable. Otolaryngology professors, the vast majority are male, only 16% are female, and amongst chairs, only 3% are females. This is from a study in 2017. When we look at minorities in otolaryngology, African Americans comprise only 0.8 to 2% of practicing otolaryngologists. And in 2016, a study looking at otolaryngology residents found that only 2% were African Americans. And there was no statistically significant change on this since 1975. And in fact, albeit with a small sample size, this was actually decreased from 3.6% in 1996. This represents the lowest figure of any surgical subspecialty compared to our peers in surgery, orthopedics, neurosurgery, etc. A study in 2013 compared us to surgery, family medicine, and internal medicine, and found we were the only specialty without a significant increase in African American representation. Hispanic Americans comprise 5% of ENT residents, but that growth rate is still only half the rate of the national population growth. Another study looked at a survey of otolaryngology program directors in 2018. They found that 37.5% of programs had matriculated one or less underrepresented minority residents in the past 15 years. And over half of programs had one or less underrepresented minority faculty on staff. So what are the barriers to diversity for us? Well, the otolaryngology match is notoriously competitive and variable. The match rate ranges from 73% to 95% for US medical students who are seniors. That's obviously difficult to plan for. Additionally, the applicants are outstanding. Step 1 averages are 248. They have 8.5 publications or presentations on their CV, and nearly half of them are AOA. And we've all seen these resumes that look like they should be for a junior faculty position. The applicant pool is insane, and that might be why the vast majority of medical students consider matching into our field to be nearly impossible or impossible. When we look at the match, we find that a similar proportion of Black medical student graduates apply to otolaryngology. That's both about 5.5%, but there's a significant bottleneck between applying and becoming an ENT resident. 5.7% of ENT applicants are African American, but only 2.1% of ENT residents are, implying that African American applicants may do worse than the average in the match. Women also appear to be less likely to apply to otolaryngology, likely for several different factors, but about half of medical graduates are females, and only a third of ENT applicants are. This might be in part because there's limited mentorship and diversity. Half of female students reported having a female faculty role model, increasing their interest in a surgical field. And female ENT applicants rated the presence of female residents or faculty very highly in importance in their decision-making. And a small minority of applicants may actually cancel interviews due to a lack of female residents. And numerous studies in other fields have shown that minority mentors have a positive impact on the recruitment of minority students to surgical fields. But a survey in 2017 of Black otolaryngologists showed that very few cited minority mentors as a motivator to pursue ENT. The authors in this study speculated that the lack of minority mentors may explain why it was helpful in other fields, but not amongst our African American otolaryngologists. In regards to career advancement, disparities have been found in compensation for both women and minority faculty. These have ranged from anywhere from 5 to 23%, even after correcting for age, experience, faculty rank, and productivity. Female faculty appear to have lower H indices, which is a research measure, earlier in their career, but over time equal or surpass the indices of their male colleagues. And this has been thought to be because female physicians have historically carried an unequal share of household responsibilities, and meetings before 8 a.m. and after 5 p.m., lack of accessible childcare near work, and parental leave issues have historically sort of been a barrier to diversity amongst our female colleagues. So we get to the million-dollar question. How do we improve DEI efforts? And I'll preface this section by saying we don't have all the answers to this. Very few areas of medicine have achieved proportional gender and racial representation, so we don't quite have the blueprint. To comprehensively fix these problems, we would likely have to look at factors like education and socioeconomic variables that begin well before medical school. But there is literature, the awareness of this has grown, that may be applicable to us as otolaryngologists. So in DEI literature, the concept of the leaky pipeline is frequently mentioned. It's the idea that at virtually every step during medical training, we leak a portion of our underrepresented minority or female students and physicians. And although literature has shown that mentorship and interventions, even in the preclinical stages, so during college and high school, of education can be effective, we'll focus on interventions in medical school and beyond. So the first steps are to form a DEI infrastructure. This has been found to be very valuable, and it's important to create leadership roles for faculty and residents related to diversity. It's important also to create institutional goals with periodic assessments of these. These formation of goals may help to move us towards a more meaningful action. Involvement of leadership early in the process is important. It's been found in studies to improve buy-in, implementation, and sustainability of initiatives. And the committee membership should be broad. It's obviously imperative to create a diversity of committee members that includes all demographics, because historically, minority faculty have shouldered a disproportionate responsibility in promoting these efforts. Key personnel that have been suggested are leaders and outward-facing faculty members, so program chair, program director, medical student director, research director, faculty diversity leaders, and residents. And I also wanted to put in a plug for our recently formed departmental DEI committee. Dr. Tillman is our point person for this. We're actually going to be meeting later this afternoon, and I know she would appreciate if anyone is interested reaching out to her and getting involved. So creating a DEI initiative. A study found that only 19% of otolaryngology programs have a DEI initiative or mention DEI on their website in any form. And that's similar to other surgical fields as well. For programs that do have these in place, there's been an increase in the proportion of female residents, albeit somewhat mild. And although correlation doesn't equate to causation, this may imply that even initial steps in DEI initiatives may be value added for recruitment. And this is an example of language that has been published on departmental websites in otolaryngology, essentially creating a mission statement for this for the department. And here at UT Southwestern, we've also been working to improve diversity from our leadership. This is our published figures in a newsletter that's sent out. From 2001 to 2015, female faculty, African-American faculty, and Hispanic faculty have all increased over 270%. On the average, we're mildly more diverse than the national averages. Female faculty are 41%, African-American faculty are 3.5%, and Hispanic faculty are 5.2%. There's also been programs implemented for career development and leadership. And on the right, we can see the breakdown of all UT Southwestern employees showing where we stand. So when we talk about preclinical intervention, so this is during first, second, and third year of medical school, we really focus on three things: pipeline programs, mentorship programs, and funding for scholarly activities. So we'll talk about mentorship first. Early mentorship is critical. It's been demonstrated to be valuable for underrepresented minority students in a variety of surgical specialties. It seems to promote a sense of belonging in surgical culture, compensates for disadvantages these students may face, and increases research productivity and retention in academics. There are really two types of mentorship: formal mentorship, which is institutionally driven, and informal mentorship, which is individually driven. And although there's some evidence indicating that formal mentorship may be better for minority students, informal mentorship is more commonly done in surgical fields. We typically find a mentor who we get along with or who we treat as a role model, and they help guide us as we navigate through the process. So if we look to the literature for strategies for mentorship, individuals have published about actively creating mentorship opportunities rather than passively creating them by working with specialty interest groups and minority and women in medicine groups to reach students early on in the process. And gender and race concordant mentorship is not essential. There's actually been plenty of benefits shown to non-concordant mentorship. And then as far as ACGME, they've published sort of milestones or goals for a mentorship relationship. Altruism is really important. That's investment in the mentee. Availability, and then competence, which means becoming a role model. And these are some other strategies from a paper I read. So what's important to a mentee is to be available and prepared, articulate expectations, be encouraging, recognize potential. That means essentially sponsoring them for involvement on other research projects, or when the time comes for applications, actively listening, being a good role model, and building trust. And we may feel like we're not as good of a mentor as somebody else. Overall, only 65% of mentors thought that they were effective at it. But most of these individuals had really high mentee satisfaction. So the reality is that we all will continue to grow as mentors over time, but virtually all residents and faculty have insight to give. More recently, we've also seen unique mentorship opportunities present themselves. We can create partnerships with national organizations that promote diversity in medicine, like the Student National Medical Association. And in 2020, 2 Vanderbilt residents actually worked together with organizations like this and minority residents across the country to host a virtual event introducing minority students to otolaryngology. It was attended by over 120 minority students. And we can also do similar partnerships with smaller medical schools, historically Black colleges and universities, to virtually mentor students who don't have home ENT programs. We also all know the importance of audition rotations and research productivity for getting into otolaryngology, but they can present barriers as well. Research productivity is obviously somewhat driven by your home program, and if you either don't have a home program or your program isn't very academically active, that can put a limit on what you're able to produce. And research presentations also have significant costs associated with them as well. Away rotations are critical to obtain for letters of recommendation. There's a higher chance of matching at your home or away program, and they're associated with significant costs though. And more recently, as programs have tried to create a smaller pool to more focus their attention on the away applicants, they can be competitive to obtain as well. And when Smith et al. Looked at the 99 otolaryngology programs, they found that only 9 had funded clinical or research opportunities for minority students, and only 8 had mentorship opportunities listed for women or underrepresented minorities. And formal pipeline programs, as we'll talk about shortly, have been effective at helping. These can be publicized or found on HeadMirror, OtoMatch, or society websites. So this was a study in procedural and surgical fields of 118 underrepresented minority medical students from 30 medical schools. It had 3 phases, but what they published on was the 8-week summer internship program, where these students shadowed surgeons both in the clinic and the operating room, learned anatomy, and completed a research project with poster presentation. Mentorship continued throughout their application process. Overall, 84 of the students applied to procedural specialties, which is a 75% retention rate, and 81 of these matched for a 96% match rate. This did not include otolaryngology, but included general surgery, orthopedics, neurosurgery, urology, and several others. When we look at a similar program in our field, published from Johns Hopkins, they sponsored the registration and a housing stipend for 15 medical students in their 3rd and 4th years to complete either a 1-month clinical or 3-month mentorship research clerkship. On average, the students completed 1.5 publications after program completion, and 6 of the 7 students who applied to otolaryngology matched, 3 of whom matched to Johns Hopkins. 6 others matched into other surgical fields. So this demonstrates that a program like this may have benefits for both the students and the program in increasing diversity. So the next thing that may be modifiable is the match. So an NRMP survey showing program director responses to the factors used to grant interviews is here. Unsurprisingly, step 1, AOA membership, grades, and letters of recommendation are some of the most commonly used characteristics when deciding who to give an interview to. There's also evidence that nearly 2/3 of programs use step 1 cutoffs to help simplify the application process. But there's evidence showing that these cutoffs and potentially these other variables may not be the best markers of an applicant's potential in our field. So dealing with USMLE scores. So medical students are increasingly coming from high socioeconomic backgrounds. And in sort of medical school applications, they found that an emphasis on testing may favor well-off applicants, because they may have fewer financial constraints, better access to test preparation courses or tutoring, and may not require as much financial support to support themselves in terms of jobs. Studies in medical school have found that female, minority, and non-traditional, so as an older otolaryngology applicants, tend to have lower average USMLE Step 1 scores by 3 to 7 points. And studies looking at the general medical population have found differences of up to 15 points. And the question has always been, does Step 1 or Step 2 scoring predict board passage rate? So this study looked at ENT residents from 2007 to 2009. The average score at the time was 238, and the written board examination pass rate overall was 95.3%. What they found is that increasing Step 1 and Step 2 scoring is associated with a higher passage rate. However, the effect is relatively small. With a Step 1 score of 232, the passage rate is 95%. At 214, the passage rate is 85%. So with applicants with below average scores, they're still very likely to pass written boards. And conversely, once you get over a certain threshold of 232-ish, it offers really minimal improvement in your chances of passing boards. Large studies in general surgery have shown similar findings, and really considering that the average score in otolaryngology now is 248, this may be even less of a concern for us now. And so as Step 1 continues to become pass-fail later this year, it's important to keep these factors in mind as we transition to Step 2 being really the only objective scoring data point we have. So Alpha Omega Alpha is an honor society that's available at many medical schools. It's chosen subjectively, sort of variably between different schools in a blinded process by chapter members. Despite the blinding, what research has found is that 2.2% of AOA members are African American, and Caucasian students are 6 times as likely to be chosen as Black students. And that's even after adjusting for objective metrics like Step 1, research, and other grades. For this reason, in 2020, many schools halted their AOA selection process until they worked through how to do it more equitably. It's also been found that dean's letters and clerkship grades may have some bias as well. Black students have traditionally been found to have lower clerkship scores on average, and those scores are based on both a subjective assessment and examination. And a study in 2018 looked into why that might be the case. And they found that underrepresented minority students received slightly lower clerkship direct ratings. And although that was a small difference, it amplified in its effect, and it resulted in half as many honors grades. When we look at research, it's certainly true that research output as a medical student is correlated with academic productivity as a resident. Studies do show relatively little correlation with subjective resident performance, though. And as we move towards pass-fail on Step 1, there's going to be an increased focus on research productivity, most likely. This may put students from smaller medical schools or without a home program at a disadvantage. And research fellowships are a common way to sort of, ameliorate that. They're becoming increasingly common already and likely will do so in the future as well. But these are typically unfunded, and you can't receive medical school loans for them. So this is going to put underrepresented minority or socioeconomically, or students from low socioeconomic status behind the 8 ball. And overall, this may create a hidden curriculum where service, leadership, and work experience are undervalued relative to academic pursuits. So the big question is then what predicts resident success? A study by Bowe et al. Looked at otolaryngology residents and looked at which factors were associated with resident success. This was a review of the literature. They found that AOA had essentially all of the factors had mixed results. AOA had 2 studies with no correlation, 1 study that correlated with increasing faculty rank. Clerkships studies found that essentially only honors in surgery was correlated with improved performance, and for USMLE, very loosely correlated with improved in-service scores. And even if you look at these in total, when you look at rank lists, a program looked at their residents and subjective faculty and co-resident evaluations, as well as in-service scores, and tried to correlate with the position that that student resident was on their rank list initially, and found that there was no correlation. So what this tells us is that our traditional process may not be as effective as we think, as some studies have shown that the factors we've been talking about aren't correlated with success. So ultimately, our job is to try to find applicants who can do the requirements of residency effectively and have the greatest potential in our field. And that's hard because the non-objective factors that we all value are difficult to access. Things like integrity, motivation, responsibility, communication skills, and professionalism. So what does the literature say about changing our interview process to become more equitable? Well, they've recommended having a diverse interview committee. Studies in the business world have shown that having 35% women on an interview committee leads to gender balanced selections. Essentially, male and female applicants have equal chances of being selected. It's also important to highlight and allow interaction with minority residents and faculty. It's important to remain cognizant of unconscious bias and the impact it may have. It's recommended to turn off applicant photos, as race and facial attractiveness are a significant predictor of reviewer ratings, and to consider bias education for the interviewing team. It's also important to potentially avoid absolute cutoffs. Loose cutoffs have been found to be more equitable. And alternatively, you can use a cutoff that's evidence-based, like for example, 232 or 235 for step 1, but then to blind interviewers to those metrics after cutoff use, because the evidence shows that somebody with a 245 is not meaningfully worse off as an applicant than somebody with a 250. It's also important to interview a diverse applicant pool. Studies have found that only when you have 2 or more minority applicants that you're interviewing do you actually have an increase seen in the chances of matching a minority applicant. Overall, focus on a holistic review that places an emphasis on the whole applicant and de-emphasizes isolated quantitative measures. Residency application review committees should discuss the value they place on extracurriculars and leadership experience, and committees should consider the ability to overcome adversity, crisis management, and demonstration of grit as part of the interview process. So to see that in action, there's a study from the general surgery program at UPenn. They compared a new holistic review process with their prior traditional approach. They expanded their interview committee and made it more diverse. They all performed implicit bias training and created an alternative scoring system that was focused on intellectual curiosity with academic pursuits, teamwork and altruism, leadership potential, motivation, and letters of recommendation. They used a loose USMLE cutoff of 220, and then scores and grades were blinded. What they found was a significant increase in both female and minority students that were ranked and that matched. For the ranking portion, the number of female applicants went up from 42 to 61%, and minority applicants went up from 14% to 20%. When they looked at objective scores afterwards, there was no difference in the median step 1 score between the ranked and matched applicants before or after the process changed. Abside scores were lower after implementation, but still consistently above the national median. And whenever they looked at subgroups, they found no differences between underrepresented minorities and female residents and other residents. It's also important to, as we've talked about, consider implicit bias. The evidence here is really mixed, and research on this is pretty difficult. What we found is implicit bias may be modifiable. Training is effective at increasing awareness of implicit bias and its effects on healthcare, but there's really limited evidence for behavioral changes or for actually reducing biases by doing interventional bias trainings. So the recommendations that for providers from the literature are to respect the presence and impact of unconscious bias, focus on empathy and perspective taking, individualize patients so that you're not using stereotypes, as possible, manage cognitive load. The busier we are, the more likely we are to sort of go back to generalizations, and then practice evidence-based medicine as much as possible. The story doesn't end once applicants are in residency. Minority residents and faculty are more likely to experience feelings of isolation with lower career satisfaction. These applicants and military veterans are at highest risk for attrition in surgical residencies, as ACGME data from 2016 shows. General surgery is 6-1, Hispanic and Black residents to other residents in terms of being fired. Internal medicine is 12-1, orthopedic surgery is 15-1. And that demonstrates a potential need for ongoing mentorship and support. Studies have also found that Black faculty are less likely to be promoted than their peers, even when controlling for clinical productivity, time on faculty, and academic productivity. This was an editorial in the New England Journal of Medicine this year, talking about how to improve faculty representation. They recommended implementing reimbursement safeguards to ensure salaries were equitable, inviting female and minority faculty to lecture on a broad range of topics, valuing non-academic endeavors and mentorship, and then providing financial support for advanced degrees like an MPH and leadership training. And these efforts can be effective. Johns Hopkins Otolaryngology Department published on a faculty diversity initiative at their institution from 2004 to 2014. They did several things at the same time. They invited women and minority lecturers. They created an endowed annual lectureship to honor female leaders in the field, had aggressive recruitment of qualified candidates to faculty, created a women in otolaryngology mentorship program, put on faculty development workshops, provided support to complete MPH degrees, and performed a financial audit to ensure that salaries were equal by race and gender. What they found in 2004 was that female junior faculty salaries were 4 to 12% lower. Over time, these were effective. Female clinical faculty increased almost fourfold to 23.7%. This was similar to what was seen amongst female basic science faculty. Female at associate professor rank increased from 0 to 8. Improvements were also seen in the number of underrepresented minority faculty from 2 to 4. And since this was all done concurrently, it's hard to say which of these interventions were most helpful. This may be a situation where making diversity a departmental priority is responsible for cultural changes that create most of this improvement rather than any individual intervention. So in summary, the US population continues to diversify. Otolaryngology and all surgical subspecialties don't really reflect these changes yet. There are significant healthcare disparities that exist. These are due to a confluence of race, gender, social determinants of health, and implicit bias. Diversity is likely beneficial for healthcare outcomes and for institutional decision-making, productivity, and innovation. And what can we consider as otolaryngologists? Well, creating a departmental DEI infrastructure is a nice first step, increasing outreach and mentorship for non-traditional students, creating funded pipeline programs for these students to pursue clinical and research experiences, implementing aspects of a holistic application review, and discussion of implicit bias and how they affect patient care and medicine, and finally supporting and promoting faculty. Thank you for your time, and thank you to Dr. Tillman for her assistance with this talk. I'm happy to take any questions.